Hello everyone. Today we shall discuss about a very commonly occurring medical emergency in dental practice, Syncope, guided by Dr. Bhushan Bhagat sir. The topics covered in this presentation are the definition, signs and symptoms, etiology, pathophysiology, types, investigations, and management. Now let us see each one in detail. Definition. Syncope refers to generalized weakness of muscles, loss of postural tone, inability to maintain erect posture, eventually leading to loss of consciousness. Coming to the signs and symptoms, before a patient experiences syncope, the dentist should be alert about the early signs that the patient shows. Therefore, in pre-syncope, we have early and late signs. The early signs include feeling of warmth in the neck and the face, pallor, BP is decreased, heart rate is increased. We can see perspiration, dizziness, and nauseousness. In the late symptoms, the patient shows yawning, coldness of hand and feet, the heart rate is decreased, dilated pupils, disturbed vision, and loss of consciousness. When the patient is in syncope, the breathing is irregular, gasping, apnea is seen, that is cessation of breathing, dilated pupils, convulsive twitching, the heart rate is decreased by below 50 beats per minute, the pulse is weak and thread, incontinence can be seen, as well as airway obstruction. If not recovered within 5 minutes of proper management, it is not vasovagal syncope. In post-syncope, we see that the consciousness is regained, there is pallor, nausea, weakness, sweating. The heart rate and BP normalizes. An easy way to remember the causes is as given in the slide. Head stands for hypoxia, epilepsy, anxiety, disorders of the brainstem. Heart stands for heart attack, embolism, aortic stenosis, rhythmic abnormalities, and tachycardia. Vessels stand for vasovagal causes, that is common faint, electrolyte abnormalities, situation due to cough, sneeze, micturition, subclavian steal syndrome, ENT causes like glossopharyngeal neuralgia, low systemic vascular resistance, and sensitive carotid sinus, sick sinus syndrome. Coming to the circulatory causes, they can occur due to inadequate vasoconstrictive mechanisms like in vasovagal syncope, postural hypotension, carotid sinus syncope, antihypertensives, that is hydralazine, hypotension, as in cases of hemorrhage and Addison's disease, or due to reduction in venous return due to cough, micturition, straining at the stool evacuation. Also, reduced cardiac output, as seen in cases of aortic stenosis, myocardial infarction, cardiac tamponade due to pericardial effusion and pulmonary embolism. In case of arrhythmias, in AV blocks, ventricular asystole, ventricular tachycardia, and fibrillation, and it can also occur due to cerebrovascular disturbance in hypertension, transitory ischemic attack. Non-circulatory causes include hypoxia, prolonged bed rest, hypoglycemia, anemia, anxiety neurosis, and hypoventilation. Coming to the pathophysiology of syncope. When the patient is anxious, it causes release of catecholamines, which leads to decreased vascular resistance and pooling of bone. Thus, the compensatory mechanisms are activated, which are manifested as increased heart rate, rapid breathing, pallor, and perspiration. Later on, decompensation causes decreased blood pressure, reduced cerebral blood flow, which eventually leads to syncope. Now let us see each type in detail. First and the most common is the vasovagal syncope. It occurs during emotional stresses, accidents, severe pain, mild blood loss, prolonged bed rest, fever, and heart diseases. It involves cardiac slowing and reduction in the systemic peripheral resistance. Assumption of supine position, elevation of legs, and removal of offending stimulus restores the consciousness. Second is postural hypotension. It is seen in patients who have chronic illness. There is fall in BP in erect posture, which causes pooling of blood in the lower limb. The causes can be idiopathic, autonomic insufficiency, peripheral neuropathy, and hypovolemia. Micturition syncope. It is seen in elderly during or after urination. There is release of intravesicular pressure, sudden vasodilation leading to syncope. Cardiac syncope. Sudden reduction in cardiac output causes cardiac syncope. Carotid sinus syncope. It occurs due to vagal-mediated cardiac slowing, fall in BP due to depressor response. Syncope can be precipitated by turning the head to one side or by tight-fitting cervical collar. Cough syncope. It occurs in males with chronic bronchitis or COPD. Due to vigorous coughing, there is decreased venous return to the heart by rise in intrathoracic pressure during coughing. Syncope of cerebrovascular diseases occurs due to narrowing of arteries. Exercise or physical exertion reduces blood flow to the upper part of the brainstem, causing syncope. Investigations. The investigations that can be carried out in cases of syncope are serum electrolytes, glucose, hematocrit, blood and urine screening, ECG monitoring can be done, and upright tilt testing. How will we manage a case of syncope? The first and foremost primary step is to stop all other treatments. The patient is to be rested in supine position and his legs should be raised. The monitoration of vitals, which includes giving supplemental oxygen and performing basic life support. Ammonia salt is kept under the nose to retrieve consciousness. This is the protocol for basic life support. If the patient is unresponsive or not breathing or no normal breathing, only gasping, activate emergency response system, get AED or defibrillator or send second rescuer to do this. Check the pulse, definite pulse within 10 seconds. If there is a definite pulse, give one breath every 5 to 6 seconds and recheck pulse after every 2 minutes. If there is no pulse, begin cycles of 30 compressions and 2 breaths. Once AED or the defibrillator arrives, check the rhythm for shockable rhythm. If it is shockable, give one shock, resume CPR immediately for 2 minutes. Not shockable, resume CPR immediately for 2 minutes, check rhythm every 2 minutes, continue until ALS providers take over or the victim starts to move. High quality CPR can also be performed with rate at least 100 per minute, compression depth at least 2 inches, allow complete chest recoil after each compression, minimize interruptions in chest compressions, and avoid excessive ventilation. Coming to the dental considerations. The first and the primary protocol is to follow the anxiety reduction protocol. First, pre-medicate the patient with hypnotics for a relaxed sleep the night before the surgery. Pre-medicate the patient on the day of surgery. Schedule the surgery in the morning. Minimize the patient waiting time. Consider psychosedation during the surgery. Administer adequate pain control measures during surgery. Reduce length of appointments and avoid anxiety during surgery. Effective post-operative analgesics can be given, and glucose administration or 5% dextrose IV if the patient is unconscious. Diazepam is a commonly given anti-anxiety drug. Differential diagnosis for syncope. Under reflex, you have vasovagal due to prolonged standing stress, pain. Situational due to coughing, sneezing, micturition, defecation, post-exercise. Carotid sinus hypersensitivity. Under orthostatic, you can have volume depletion, medication effect due to alpha blockers, antidepressants, and antipsychotics. Autonomic failure, like seen in Parkinson's, diabetes, alcoholism, amyloidosis, multiple system atrophy. Cardiogenic in bradyarrhythmias, seen under sinus bradyarrhythmia, sinus pauses, AV block, tachyarrhythmia, ventricular, and mechanical causes due to aortic stenosis, HOCM, and PE. That is the pulmonary embolism. Syncope mimics. So seizure can also commonly present as syncope. Cerebrovascular syncope consists of vertebrobasilar insufficiency, subclavian steal syndrome, alcohol blackout, sedation, and psychogenic pseudosyncope.